Welcome to ATCM, the Emergency Medicine channel.
Yes.
Today we'll be discussing about ATLS, hypothermia. So the objectives we'll be discussing about is to identify the problems encountered with hypothermia and explain the mechanism and risks posed by hypothermia patients in injured patients, and define the 3 levels of hypothermia, and also describe the treatment approaches for hypothermia. So hypothermia is defined as a
hypothermia in European Resuscitation Council guideline is different from hypothermia mentioned in ATLS. So for those people who are planning to attend that Emarcum OSCE station where you may get hypothermic cardiac arrest as a scenario, then you will have to follow the ERC guidelines, European Resuscitation Council. But this ATLS hypothermia, it's another chapter. But for those people who are writing OSCE, always go according to ERC.
So the hypothermia is defined as a core body temperature. It's below 35 degrees Celsius or 95 degree Fahrenheit. And in the absence of any concomitant traumatic injury, the hypothermia can be classified into 3 types. It is mild, which is between 35 degrees Celsius to 32 degrees Celsius. And moderate is between 32 degrees Celsius to 30 degrees Celsius, or severe. Severe is below 30 degrees Celsius. So this is in the case of if there is absence of any concomitant traumatic injury. And in the presence of a traumatic injury, the definition, the 3 types of hypothermia differs. So the mild hypothermia is 36 degrees Celsius, and moderate hypothermia is less than 36 degrees Celsius to 32 degrees Celsius, and severe hypothermia is less than 32 degrees Celsius. So that's the difference between hypothermia, the different types of different severity of hypothermia based on presence of injury or absence of injury. And there is also some another classification based on its timing. It's the acute hypothermia.
So I think we can better go with those people with injury, because we are dealing with the ATLS, so it's a trauma case. So we can stick on to that aspect. Those with injury, how is hypothermia defined?
Yes, sir.
Here, mild, moderate, severe.
Yes.
Mild is
36 degrees Celsius.
36.
Yes. Moderate is less than 36 to 32 degrees Celsius.
Yeah, 32 degrees Celsius and above till 36.
Yes.
To less than 36.
Yes.
Okay.
And severe will be less than 32 degrees Celsius.
All right.
So this hypothermia can also be staged clinically. So it is based on a staging system called as Swiss staging system. So the Swiss staging system is based on 4 stages. So the first stage is it's a stage of conscious shivering. It is between the temperature of 35 degrees Celsius to 32 degrees Celsius, and the treatment for such conditions is mainly warm environment and clothing, along with warm sweet drinks, and also active movement if possible. That is mainly the treatment in case of stage 1 of the classification of Swiss classification. And in stage 2, it mainly involves impaired consciousness, and the patient is not shivering. So in that, the core body temperature will be between 32 degrees Celsius to between 28 degrees Celsius to 32 degrees Celsius. Okay. So that is the temperature range. And in such patients, the patient 28 to 32. So in such individuals, the patient requires cardiac monitoring.
To less than 32 probably.
Yes, less than 32.
32 degrees is what?
32 degrees is conscious shivering. So 32 to 35 is conscious shivering. The first stage 1.
32 or more, or is it like?
32 is included in stage 1.
32 is included in stage 1?
Yes.
Okay.
Yeah. Less than 32 is included in stage 2.
All right.
Yes. And so that involves cardiac monitoring. So mainly it involves, there can be, and we must always monitor to avoid arrhythmias. So there will be the presence of arrhythmias, and also we must maintain immobilization for such, and full body insulation, and active external rewarming must also be done. We'll be discussing about the rewarming methods later.
So the Swiss classification
yes.
of hypothermia, but this is for non-injured cases.
Okay.
Because you have told 35 degrees, right?
Yes. This is for in the case of accidental hypothermia cases.
Accidental
Hypothermia cases.
It's not for
The
injured hypothermia.
Yes.
Okay.
So next is the stage 3. Stage 3 is involving the unconscious and not shivering patients, but the vital signs are present. So such stages are usually in the temperature range between it is less than 28 degrees Celsius to 24 degrees Celsius. So in those temperatures we will be classifying as stage 3. And in such cases we must always do management as stage 2, plus we must also manage the airway, and airway management along with ECMO is also needed in cases which are refractory to the medical management provided before.
So what is the relevance of this staging thing?
So the staging is mainly in how we resuscitate the patient is based on this temperature range and the clinical symptoms associated. So the
basically when you get a case, you don't really have the time to check the temperature and all.
Yes.
So immediately on looking itself, if patient is conscious and shivering, you can assume that patient is in stage 1.
Yes.
Because when you get a scenario like that, patient is brought after RTA, whatever, or this thing, patient is conscious but shivering. One scenario will be like that. Second scenario will be patient is conscious, consciousness is impaired but not shivering.
Yes.
Then patient is in stage 2. So indirectly, then and there itself, you are getting a clue. Even before you do your primary survey, in the initial 10-second assessment itself, we have got seen that the patient was in a cold climate or whatever, and then this is the state. Means immediately your focus should be whether the patient is having hypothermia or not, because ultimately to diagnose hypothermia, you should check the temperature.
Yes.
And then that temperature checking is usually done in which stage? Exposure. A, B, C, D. Once you finish A, B, C, D, E, when you come to E only, then you get to know that the patient's temperature is low.
Yes.
Otherwise, in this scenario, from the start itself, you know that the patient is having hypothermia. Okay.
Yes. And in the case of patient in stage 4 of the Swiss classification, it's mainly in the clinical symptoms, there's the absence of vital signs. So it usually occurs in a typical core body temperature of about less than 24 degrees Celsius. And in such cases, we must also give the management as in stage 2 and stage 3. Along with that, we must also start CPR. And so this is the it is actually in ATLS guidelines. They have told that we can give up to 3 doses of epinephrine and defibrillation, with further dosing guided by clinical response. So there is a difference compared to the ATLS guidelines and the European Resuscitation Council guidelines, which we'll be discussing later. And so they are also told about active CPR, prolonged CPR with active external and internal rewarming. So there are also
stage 1 management is warm environment and clothing, warm sweet drinks, active movement. Stage 2 is cardiac monitoring, minimal and cautious movements to avoid arrhythmias, horizontal position and immobilization, full body insulation, active external rewarming. Stage 3 will be management, stage 2 management plus airway management, ECMO or cardiopulmonary bypass in cases with cardiac instability, that is refractory to medical management. And stage 4, stage 2 plus stage 3 management plus CPR, because patient is in cardiac arrest.
yes.
And up to 3 doses of adrenaline, 1 mg, and defibrillation. And further dosing is guided by the clinical response.
Yes.
And then rewarming with ECMO or CPB.
Yes. So based on the timing, we can also classify again hypothermia as acute, subacute and subchronic. So there's actually 3 types of hypothermia again. It's acute hypothermia usually occurs rapidly with sudden cold exposure. It's usually in the case of immersion in cold water or in an avalanche. So his patient is stuck in an avalanche. So in such conditions, the patient will have an acute exposure to sudden low temperature. So in those low temperature, the sudden low temperature will the body will not be able to compensate to the sudden low temperature. But the hypothermia manifestations would take about 30 minutes to establish. And in subacute hypothermia, it is usually due to the depletion of the body's reserves to manufacture heat. So it is usually accompanied by hypovolemia in such patients. And usually its treatment is administering warm fluids. So that is and by rewarming the patient's body externally. So these are by how we manage a subacute hypothermia. And there is also a presence of a subchronic hypothermia, which occurs when there is a prolonged exposure, but to a slightly cold temperature, but prolonged exposure. So and the regulatory response is not adequate. So mainly it is seen in older individuals because they may not have adequate thermoregulatory mechanisms to counter the cold temperature. So it's usually when the case of a patient having a scenario is usually in the case of old individual having a sustained fall, having a hip fracture, and he's having maintained a prolonged immobilization. So such individuals are susceptible for subchronic hypothermia.
Question that you will get: elderly fractures lying unresponsive, and scenario will be like that.
Yes.
And what would be the why? You would be asked why the patient is lying unconscious. So probably question the essay will be on hypothermia,
Yes,
but you will think it is basically about hip fracture.
yes.
The essay will be framed on hypothermia. The scenario will be like that.
Yes, sir.
So you should be cautious.
Yes, sir. So the two main groups which are more susceptible to hypothermia is mainly the older individuals and the children. So in older individuals, they are mainly susceptible due to their decreased heat production, increased inability to produce increased heat, and also due to the heat decreased there's presence of vasoconstriction. So that's also one of the cause. And in case of children, there is a presence of increased body surface area. So there can be presence of increased heat loss. And both of these group of individuals are more susceptible to hypothermia injuries because both of these people, in case of an massive injury situation, they may be finding it difficulty to mobilize. So in such situations, they will be stuck to short temperature for a long time. So that can also be possibility of them to undergo hypothermia injuries. Okay. So
acute, subacute, subchronic, and chronic.
Yes.
Hypothermia.
Yes. Now next is it is determine the core body temperature. So which are the areas mainly the areas which we measure for the core body temperature is involving the esophageal or the rectal or bladder temperature is mainly used to diagnose the systemic hypothermia, or we can use the tympanic ear temperature is which is used for external.
We should use a low reading thermometer, not the usual thermometer that we use here. We use it in the axilla and this mount or in the mouth and all.
Yes,
but this is a low reading thermometer. In ARC guideline, I think for conscious patient you can use the tympanic temperature.
Yes.
We use, but if the patient is intubated or if then esophageal temperature has to be monitored. Thermometer has to be used.
Yes. Moving on to the signs.
They have already also mentioned about bladder.
Yes. Bladder
temperature. And the rectal temperature also.
Yes. So moving on to the signs of hypothermia, how we can present based on its severity. So mainly in mildly hypothermic patients, as mentioned before, patient will be presenting with shivering. So the shivering mechanism is usually present. Along with that, the skin is cold to touch due to vasoconstriction. And in moderate hypothermia, usually the patients can have a mental disturbance, like mental confusion. There must be an altered sensorium associated with slurring of speech or apathy or amnesia. Neurological symptoms can also manifest in the case of moderate hypothermia, because as I said before, in stage 2 there is presence of impaired consciousness with no shivering. So that's
mildest usually goes with Swiss 1
yes.
Staging.
Yes.
Whereas moderate goes with from Swiss stage 2 onwards.
Yes. And
consciousness, some impairment is there.
Yes. And the case of severely hypothermic patients, they usually have the symptoms of mainly autonomic symptoms also, mainly involving bradycardia, hypotension, and also fixed dilated pupils. There can be also the presence of apnea and can further move on to cardiac arrest. So in hypothermia patients, the heart rate and the BP are all variable. So we can't always because of this hypothermia, the respiratory center and the heart rate can be suppressed. So that will, in the severe cases, it can cause as manifestations of severe hypothermia. And the physiological effects what hypothermia can cause in our body. So mainly there will be the presence of the fall in cardiac output. The cardiac output will be reduced, and also in the ECG there will be mainly findings which are usually non-specific. But
Cardiac output is reduced probably because of low heart rate.
Yes, heart rate into stroke volume.
Stroke volume into heart rate.
Yes.
Okay.
So and ECGs mainly can be non-specific, but there can be the presence of J waves. That's called as Osborne waves. So an additional wave after the upward deflection after the QRS complex.
Osborne J waves. That will be given for your Viva. One ECG will be given. Identify the ECG. Should be careful.
Yes. And
Osborne J.
Next manifestation which can be seen in ECG is about ventricular fibrillation, which usually occurs in temperature less than 28 degrees Celsius, and even temperature less than 25 degrees Celsius, as we have mentioned before, in stage 4.
25 or 24?
Below 25. 25. Yeah, in Swiss classification, as mentioned, is stage 4. Patient can move into asystole. So patient asystole can also occur. These are the usual physiological.
So when you check for this thing, pulse and all, minimum 1 minute you should be checking.
Yes.
For central
pulse
in case of hypothermia.
Yes.
Okay. Before initiating CPR and all.
Yes. So usually in the cases of if in cardiac arrest situations, if there is presence of acidosis, severe hypoxia or hypothermia, in these conditions even cardiac drugs and defibrillation are usually not effective. So initially we must correct the triggers which are potentiating the cardiac arrest.
So what are the ones?
Hypoxia, in the acidosis and hypothermia. So in these 3 situations which are triggering cardiac arrest, we must address these issues too before giving the cardiac drugs and defibrillation also. And
so correct all reversible causes.
Yes, the reversible causes. Yeah. And next is mainly about the management. So in management, usually before reaching the management, I'll just be briefing about the rewarming techniques. The rewarming techniques mainly we have passive rewarming techniques and active rewarming techniques. So the passive rewarming techniques is usually used in the case of mild hypothermia between 35 to 32, and in passive rewarming techniques mainly involves to dry the patient and also keep him in a warm environment, and shivering is also a method of passive rewarming, and also blankets or clothing, and also covering the head of the individual. So these are the passive rewarming techniques. Active rewarming is again classified into 3 types. It's again classified into external rewarming techniques and internal rewarming techniques, and also extracorporeal rewarming. So the external rewarming techniques mainly.
This one it will be a question, okay?
Yes.
This rewarming techniques in hypothermia can be a separate question as such for exams.
So
you should know the passive rewarming, active rewarming. Under active rewarming, 3 headings: external, internal, and extracorporeal rewarming.
Yes.
Okay.
So in active rewarming, it mainly the first one, it involves the external rewarming. So an external rewarming can be used by using heating pads. Heating pads can be used, or we can use warm water, blankets, and even warm water immersion can be also used along with we can use radiant warmers, or usually external
bear hugger and all, no? Can use
external convection heaters. So usually there are external convection heaters that can be used. Examples are using of radiant lamps and radiant warmers. So it is mainly used in the case of mild and moderate hypothermia. And internal rewarming we mainly used by heated IV fluids. So heated IV fluids, we can use gastric or colonic lavage with even with warm liquids, and we can use peritoneal lavage or mediastinal lavage is also there, or we can use warm inhalational air or oxygen. So these are the methods of
that is when temperatures between 28 to 32.
Yes. So it is
active internal rewarming.
So that's mainly the case of moderate and severe hypothermias we can use.
But if it is 32 to 35, just active rewarming using external. Only if it is below from 28 to 32, use internal rewarming. And the other one is between 32 to 35. The passive rewarming.
Yes.
Okay.
So in case of severe hypothermia, in such cases,
that means 24 to 28.
Yes, 24 to 28
degree, okay.
Or even less than that. In such situations, we use extracorporeal rewarming. So that is mainly by methods of hemodialysis, or we can also use a cardiopulmonary bypass. So ECMO is it's mainly involved in the case of severe hypothermia. So this is how the management is in the case of the different techniques in the case of hypothermia.
In all these cases, pulse should be there. Central pulse should be there.
Yes.
Okay. It's not like central pulse is not there and you do hypothermia management. It's not like that. Okay.
Yes. So even this using this extracorporeal assisted rewarming in severe hypothermia, this rapid rewarming is possible by this technique. Like rewarming rates up to 1.5 to 10 degree per hour. So that much we can bring back the temperature by using extracorporeal methods of rewarming. 1.5 to 10 degree per hour.
Per hour.
Yes, we can increase the temperature.
Celsius.
Yes, degrees Celsius. Okay. So this is about the different rewarming techniques. So next is about the rewarming strategies. Is also mentioned in the form of a flow chart in the next page. So that's just what I mentioned before itself. It is briefly mentioned in it. So next is about how to determine death in cases of patients with severe hypothermia. So in patients who have appeared to have had a cardiac arrest or broad death, in the case of hypothermia, we must always make sure that we rewarm the patient and bring the patient to the core body temperature, normal core body temperature, before classifying them dead. So that's the first thing, because it's always told that you are not dead until you are warm and dead. So that is the main axiom that is associated with it. So there are actually two exceptions to this rule. So in the first cases, if patient had a death due to an anoxic event while he was normothermic. Initially he was normothermic, he had an anoxic event and he had died and he was brought in a hypothermic state. In such situations, we do not need to rewarm the patient for him or her to classify as death. And in next situation is mainly in the patient who is having a potassium level more than 10, greater than 10. In such situation also no need to rewarm the patient. Another exception is patient who is present with a fatal wound. So in the case of any transcerebral gunshot wound or complete exsanguination injuries or hypothermia, in such situations also we do not need to rewarm the patient to classify the patient as dead.
Okay. So these are the three conditions. What are the three conditions?
So
for not rewarming a patient.
In severe anoxic injury.
Yeah. The patient is already, not the spot itself, already because of hypoxia, patient got arrested.
Yes. Yes.
Then you are sure that it is a hypoxic cardiac arrest.
Yes.
Hypothermic cardiac arrest is not the
cause of the arrest.
So then you can stop further rewarming, the resuscitation and rewarming. The other one is patient after an accident, patient has lost considerable amount of blood, then hypovolemic hemorrhagic shock and cardiac arrest. Then there's no point. Or if it is a gunshot wound, straight away through the head, it's gone, brain is gone, then there's no point rewarming, because it's anyway it's not going to come back. So rewarming is not indicated there. And then the third one is the potassium is more than 10. So hyperkalemic cardiac arrest. Because if there are other evident causes for a cardiac arrest, like this hyperkalemia and all, you need not initiate rewarming strategies to correct hypothermia.
So just we'll also brief through the European Resuscitation Council guidelines for hypothermic cardiac arrest in the case of accidental hypothermia. So in the case of they have mentioned it in the it's as a flow chart. So I'll be just briefing through the valid points. So in accidental hypothermia, initially we must always assess the core temperature with a low reading thermometer. Usually if patients like before cardiac arrest, if he was like if patient just presented with an accidental hypothermia without not in a cardiac arrest state, we usually, as mentioned before, we check for the temperature by the tympanic method. But if patient is already intubated, was brought intubated, we usually check the temperature by the esophageal or if there's presence of a supraglottic device also, esophageal channel is the area through which we check the core body temperature. And the presence of the vital signs, as mentioned before, the vital signs, we must look for the pulse, the central pulse must be looked for at least 1 minute to classify that patient is in a cardiac arrest. And also the hypothermic patients usually who are in the imminent risk for immediate cardiac arrest. So they are usually those individuals are having a core temperature less than 30 degrees Celsius, or patient having a ventricular arrhythmia, or a systolic blood pressure less than 90 millimeters of mercury, and those in cardiac arrest. So these individuals must be ideally brought to a center where ECMO is available. So mainly and extracorporeal not ECMO, extracorporeal life support. So extracorporeal life support mainly in the form of hemodialysis or cardiopulmonary bypass is available. Such the patient must be transported to such centers. And the hypothermic cardiac arrest patients, there is also an idea of a prolonged CPR. So compared to the standard ATLS protocol, we must if it is usually for 20 minutes, the CPR must be prolonged to the double of the time. So the cardiac arrest CPR must be prolonged for almost 40 minutes or more. So that is what is the difference between a normothermic and a hypothermic cardiac arrest. And in the case of ventricular fibrillation, so in the ventricular fibrillation always
otherwise usually if you get in a case of cardiac arrest, if there is 20 minutes of asystole despite CPR, you stop resuscitation. Yes. But in this case it is doubled to 40 minutes.
Yes. So next thing is that the if ventricular fibrillation is there, initially if patient is having a temperature like more than 30 degrees Celsius, we if he's having less than 30 degrees Celsius and a patient is in a ventricular fibrillation, the maximum number of shocks we can give is to a maximum of 3 shocks. So that until the core body temperature is more than 30 degrees Celsius. So if the patient is having a core body temperature less than 30 degrees Celsius, the maximum number of shocks which we can give is 3 shocks. And the next thing is in cases of temperature less than 30.
Beyond that, you just continue CPR, right? Continue CPR.
Yes. And maintain the rewarming.
The patient
techniques.
is in VF, the temperature is less than 30, as per the ERC guideline. If the temperature is less than 30, patient is in VF, you give 3 shocks. And then 4th shock you don't give. Afterwards, you just keep doing CPR. And once the temperature is more than 30, you can start with drugs, adrenaline.
Yes.
But here the adrenaline usually we say between 3 to 5 minutes and all. Every 3 minutes, adrenaline every 3 minutes, right? Yeah. Here you can say adrenaline every 6 minutes.
Yes.
So double, the interval should be
doubled.
So
usually, as mentioned, sir, like in the case of normothermic cardiac arrest, we give adrenaline at an interval of 3 to 5 minutes. But here, in the case of hypothermic cardiac arrest, and that too if the temperature is more than 30 degrees Celsius. If the temperature is less than 30 degrees Celsius, we should not use adrenaline in the case of cardiac arrest. So if the temperature is more than 30 degrees Celsius, we must use adrenaline, but an interval of between 6 to 10 minutes. So that is double the time of more than 3 to 5 minutes must be kept in note.
This is as per the European Resuscitation Council guidelines. It's not given in ATLS book.
Yes. In hypothermic arrested patients also, usually if patient is less than 28 degrees Celsius, as mentioned before, there is an idea of a delayed CPR, and also there is also a like if patient is not able to, we are not able to maintain a delayed CPR, even intermittent CPR is also now under study, so that we can keep a small gap in between the resuscitations.
This is based on ATLS or?
This is based on European Resuscitation Council, ERC guidelines. And next is about in hypothermic cardiac arrest, the rewarming should be performed with ECLS, as mentioned before, mainly by preferably they are mentioning about an ECMO more than a cardiopulmonary bypass. So ECMO is preferred more than cardiopulmonary bypass. And next is about a scenario in the mentioned in European Resuscitation Council guidelines about an avalanche rescue. So that's another topic we'll be just going through. So avalanche rescue in such situations, if usually patient is coming in cardiac arrest, if patient is in an avalanche was brought in, and in such situations, initially we must start with 5 ventilations itself. We must start with 5 ventilations because hypoxia is the most likely cause of cardiac arrest.
This is also given in ERC.
Yes, ERC. Okay. So in ERC it is mentioned about 5 ventilations in cardiac arrest initially itself, because hypoxia is the main trigger of cardiac arrest in case of an avalanche.
So rescue breath. Okay.
So then the standard life support protocols must be done in the case of burial time less than 60 minutes. Like in ACLS. But the thing is, if patient is having a burial time more than 60 minutes, we must always do the methods as mentioned before, like the rewarming techniques and mentioned in the guidelines before. And also they have also told about CPR is said to be futile in cardiac arrest if it is mainly depending on whether the airway is obstructed or not, if time is more than 60 minutes. So in the cases where airway is not obstructed, the initial management should always be to secure the airway. So to secure the airway and then manage the hypothermia part. So it's always about initially securing the airway. So if the airway is obstructed and we are not able to secure the airway, then the cardiac arrest all mechanisms is said to be futile if the duration of burial is more than 60 minutes.
60 minutes.
More than 60 minutes. So this is what.
So that can come as a question, Marxium and all. They'll say the burial, the time is 70 minutes. What is the appropriate line of management? 5 options will be given. Or if they'll just change the word, 60 will be changed to 30 minutes. What is the first line of management? So it will, depending on the time, the management will change. MCQs are framed in such a way. Some subtle numbers will change from here and there.
Yes.
Be more than 60, less than 60.
Yes.
I don't know. And some drugs are there, no, which are likely to precipitate hypothermia. Isn't it mentioned?
Yes, sir. Usually in the cases of it is mainly non-medical cases. So like in cases of presence of opioids or alcohol, there are toxins such as alcohol or opioids can precipitate hypothermia episodes. And also certain disease conditions such as in hypothyroidism can present, patients can present with hypothermia.
Tricyclic antidepressants. I remember some certain drugs which are likely to make this patient more prone for hypothermia.
Yes.
So that is the importance of taking drug history,
Yes.
Hypothyroid, antithyroid medications.
Yes.
So in this ATLS scenario, usually you don't get they don't keep a case on this thing. Hypothermia. Like when you resuscitate a case, suppose patient is having some chest injury. On top of that, they won't usually place a hypothermic event also.
Yes.
Because hypothermic cardiac arrest is an entirely different this thing.
Scenario.
The ATLS or ALS resuscitation station, if there is a hypothermic cardiac arrest, they are checking on a different domain.
Yes.
But if it is a ATLS, if the station is a trauma station, they usually confine themselves to either head trauma, neck trauma, chest trauma, abdominal trauma, long bones, like that.
Yes.
But in between, suppose once you reach E, if they say the temperature is 32 degrees or 30 degrees, then you may have to say, yeah, I will initiate on. Well, that is a clue.
Yes.
Patient does there's a patient, there's a trauma case, he sustained an avalanche, some trauma is there, patient is brought to you, and on reaching E only, you will get to know that the temperature is so and so. Then at that point, you can just give a word that you will initiate on this thing.
Rewarming techniques.
Rewarming techniques. Because initially they'll say the patient is shivering and things like that. Which usually, like, patient is conscious shivering. That means Swiss
Stage 1.
Stage 1. So this passive rewarming tech. So I can once you reach E, they'll say the temperature is 34. So you'll say I'll initiate passive rewarming technique. Over. So that's a clue.
Yes.
If unconscious and not shivering, and the stage changes.
Yes.
In that case, you'll have to place a definitive airway, and then once you reach E only, they'll say the temperature is 31, like that.
Yes.
So then this thing, active rewarming, has to be mentioned at that point. Got it? No?
Yes, sir.
In that way, you should be always ready with your points. Whenever the examiner says one thing, you should have the next card to place. It's not like you shouldn't be stuck in that at that point.
Yes.
Okay. That's all.
Yes.
Okay.
Thank you.
Thank you.